Hello, everyone, and thank you for joining us. My name is Eric Donnenfeld, and I am one of the luckiest ophthalmologists around. And that I'm joined today by my good friend and leading optometrist, Doug Devries. And Doug brings a world of expertise into the management of dry eye. And today we're going to be talking about a topic that I feel is extraordinarily important and a topic that really changes the way I manage patients. And I think it's really important to also mention this is a place where optometry and ophthalmology work best together, and that's the management of dry eye and specifically meibomian gland disease. Every single patient benefits from managing meibomian gland disease, and that's the title of today's conversation. That is MGD, Take Control of a Growing Challenge, a clear look at MGD. And we're going to be talking today about the Systane iLux device, which provides localized heat and pressure in adults with chronic disease to the eyelids, including meibomian gland disease, also known as evaporative dry eye. Doug, do you agree that dry eye is extraordinarily important in your practice as well?
Oh, absolutely, Eric. It is really become a keystone. As we look at referrals coming in from local optometrists and then actually taking control of that surgical patient to optimize the surface prior to actually scheduling that patient for surgery. And really trying to just optimize measurements as much as we can. But, I think especially in the face of this pandemic, in the face of the increasing screen time that we have, people wearing masks, we're seeing more inflammation, and we're just seeing more and more dry eye. And of course, MGD is going to be that leading culprit with some 86% of those dry eye patients having MGD. So yeah, absolutely.
So I'm going to go out and say that there is an epidemic in the United States of MGD, and it's multifactorial. A lot of it has to do with increased screen time, as you mentioned, but also has to do with the obesity epidemic. Patients are consuming too much fat, saturated fats, and we're not consuming enough omega-3s. So we're seeing this epidemic of meibomian gland disease, and let's learn a key aspect today of how to take control of meibomian gland disease in your practice. I'd like to mention that both Doug and I are consultants with Alcon, and we are reimbursed on this promotional program. This covers Alcon products. It's FDA approved. And if you have any issues or questions, please notify an Alcon representative. We want to make sure that this is a fair and balanced conversation.
And today, what we're going to be talking about is we're really going to look at just in general, that epidemic that you spoke of, Eric, is dry eye. And of course, MGD being the major component of that. We'll look at the tear film and really preoperative environment of what we see with these patients. And then we're specifically going to talk about Systane iLux, the thermal pulsation system. So in other words, we're going to present a problem and then we're going to show an answer to this particular problem. And we're going to do that by also going over cases, particular cases that may pertain to your practice. And I think you'll find these cases will pertain to most individuals in their practice. And then really implementation and how to get this involved and work it into your patient flow and work it into your practice and be able to really initiate this type of treatment. And I think that this, particularly as you'll see with this iLux, with its small footprint, really lends well for those patients who haven't adopted taking care and treating meibomian glands.
So Doug, you and I are going to be co-managing this conversation today, and we'll be having a great conversation about how to manage dry eye, specifically with the iLux MGD thermal pulsation system. And I think this is just a great template for how our practices can work together to optimize patient results. So I've already said this, and that is dry eye is a growing challenge in eye care. And I'm going to make a very blanket statement right now, Doug, and that is to say that in my practice, I'm going to guess in your practice too, that dry eye disease is the single most common reason why patients walk into our practice. If you look at Medicare diagnostic slips, you'll see that dry eye is absolutely number one. It's a extraordinarily common problem, and it's really been for years the back pain of eye care, optometry and ophthalmology, because it's been a disease that's extraordinarily common. Everyone complains about it. And we as professionals for years haven't really been able to do much about it. Now we have made some significant advances over the last decade or two, and realizing that dry eye is an inflammatory disease, and managing both aqueous deficiency and evaporative dry eye has really changed the way we approach dry eye. But at the same time, we have to realize that we are fighting a losing battle right now, and that we're not making enough of a dent into the patients who have MGD, and the demographics are extraordinary. It's suggested that there are 35 million Americans who suffer from dry eye symptoms in the United States. And before I go on to the economic side of this, I want to talk about the psychological impact of a chronic disruptive disease that affects quality of life. Doug, in your practice, what happens to these dry eye patients over time? How do they react psychologically?
Well, when you take a look at how that can affect somebody, and a patient that always comes to my mind, and this was a young individual. I mean, we tend to pigeonhole and say, well, it's an older population, but this was a 42-year-old urologic surgeon, and she had really hit the pinnacle. She was the head of her department. She had extraordinary skills, and when she came in, she could no longer operate, and she couldn't even do her administrative. So the psychological impact on her was absolutely phenomenal. I mean, she was an individual that had a lot of psychological problems, because now going through all that training and not being able to, and you see different people, whether they're in bookkeeping or they're in reservation management, they're spending time on light emitting devices, and not being able to effectively do that. When that happens, that impact is huge. And when we look at 35 million, I think, Eric, that's exactly why it's so common that we haven't really, in the past, we really didn't have much to do for these patients. And so I think we tend to kind of ignore it. And now with the technology that we have, there really is, this is the time to jump in, because when we look at all of these patients going without care, in our practices that are always being hit with decreased reimbursement, there's only two things we can do. We can either see more patients, or we can provide a higher level of care to the patients that we're seeing. And this is one of the examples. By taking care of this, it affects somebody's psychological aspect so much.
Yeah, no, and I completely agree with you about this. And there have been studies that have been performed and published that show that patients believe that dry eye disease is as clinically significant to them as heart disease. They view that the ramifications of dry eye and anything that affects the sense of vision is a profound effect on quality of life. So not only is a psychological burden, I show here, it's also an economic burden, $3.8 billion a year. And that's the cost of managing dry eye. It's also the lost revenue. People are just less productive when they have dry eye. You can't stay on your computer as long. You can't drive a car as efficiently or as long. You can't even open the windows sometimes because the wind blowing across your eyes creates dry eye. So this is an enormous economic burden on the entire country. I said this a million times, and I'm going to have a bumper sticker made for my car, Doug, and that says that vision starts with a tear film. The tear film is the key to visual acuity. All of the amazing technologies that you and I use to improve patients' quality of life are negated by a poor tear film. So I could have a $500,000 excimer laser, femtosecond laser, put in premium IOLs, but at the end of the day, if the tear film isn't good, the patient's not going to have a quality visual outcome. The greatest change in refraction occurs at the air-tear interface, and dry eye takes away from vision quality. Dry eye is also very important to me as a surgeon, in that I know that consistency of pre-surgical measurements are extraordinarily important. And when you have an abnormal tear film, the quality of those pre-surgical measurements is just not very good. The keratometry is markedly disrupted. When I first started doing cataract surgery, the main risk factor for a poor result was the axial length, or the biometry. Now with optical biometers, they become so accurate that it's actually the keratometry, which is the rate limiting step for my patients in cataract surgery. So I want to make certain that I can optimize the tear film, improve my keratometry to get better consistency of pre-surgical measurements. Bad corneas yield bad pre-surgical IOL calculations.
Probably one of the best instruments we had in the early days of refractive surgery was our topography. As soon as you looked at a topography, because it's not taking a picture and not taking a map of the cornea, it's taking it of the tear film that covers that cornea. So we would look at these and we'd say, you know, there's a problem with this. There's some dryness on this cornea. So even something we were using to capture was one of the leading indicators that would initially. So I'd have the technicians label that it was a patient that had tears with the topography or did not have tears, just to really kind of sort that out, because we'd see this marked improvement. So yeah, to that point, you know, one of the early tests we used was topography.
And that's a nice pearl to take home from tonight. And that is, you do topography on a patient and you see an irregular cornea, or even more significant, you see dropout with loss of data. We have little white spots in the middle of your topography. That means your tear film is so disrupted that you can't take a good topography, which means you can't get good IOL measurements.
The tear film is so important, as we covered, you know, that point in that last slide. So why manage meibomian gland dysfunction? Well, we know that that's such a leading comorbidity in dry eye, and possibly the, you know, the leading cause of having that and disruption of the tear film. Because when we get that disruption or that reduction in meibum, we're going to get the disruption in the breakup time in the tear film, which is again why those topographies just didn't show up right, is because we just had this unhealthy, poor quality tear film that really lacks the lipids and will break up fast. So when we look at the tear film and the health, it's really going to give the accurate light refraction, as well as just the comfort and giving those readings that we talked about, Eric, to really help make a determination what's the best surgical plan for that patient.
Couldn't agree with you more. You know, for years we've known that the tear film health is the key for all of the different issues that you've alluded to here. But what we haven't really understood is just how important meibomian gland disease is, and probably meibomian gland disease is 3 times more responsible for dry eye than aqueous deficiency. So while aqueous deficiency is important, managing meibomian gland disease is really the key to improving the ocular surface.
Absolutely. And that ties right into then, you know, that's the problem. What is the solution? And that is the thermal pulsation, being able to heat those meibomian glands up in such a manner that it's provider controlled. And I think that's such an important aspect of this handheld device, is that you can heat this up, you can personalize the care, because what I'll do is I'll take a look at the meibomian glands and really design a plan for myself or the technicians in applying this to the patient. So we're really personalized care, and it's giving success for those. We're going to see that in the studies. But something else we do is we enhance the revenue stream with the practice. So you know, I described this, and I think this is important on describing this function to patients. And the way I describe it to patients is we're going to heat these little oil glands up, and we're gently going to compress them. And it's kind of like squeezing the bottom of a toothpaste tube. We're going to go from the inner lid to the outer lid to remove that and clear the ducts, so the meibum can then have free access, and that is patent, so that the new meibum that's produced gets into the tear film and holds that tear together.
So what I like about this also is that it combines excellence in technology with the clinician aspect as well. So there's some expertise involved in this. You know, you're going to actually look at the meibomian glands, heat them up, and then you're going to actually watch the meibum being expressed due to your efforts. And it really allows you to personalize the therapy to exactly the lids that need the most treatment. And you can really do a great job of expressing this. And I had this done on myself. It's comfortable, it's effective, it works very quickly. And what I really like about it, Doug, is that for a big practice or for a practice with many offices, it's completely portable. It's about the size of an electric toothbrush, and you can bring it with you. You can bring it from room to room. It's not one of these devices that requires a big footprint that you have to bring the patient to this. In this case, the mountain goes to Muhammad, which is really what you want. And it allows you to be very effective in doing this. I could see a great use, for example, to bring this to a clinic or bring this to a nursing home and really creating a better quality of life for numerous patients in a very simple and effective manner.
Yeah, I really do think this device is ideal for individuals who, and practitioners, eye care providers that want to start providing. And, they're not sure how they get involved in this. It really is something that fits nicely into the being able to go room to room, not taking up much space. It really provides an opportunity for individuals to get started to really embrace the whole treatment of treating MGD within the office. The treatment really is 8 to 12 minutes, and that's for all 4 eyelids. It has a very efficient LED that heats the eyelid up. And you're going to see in a video that we have how it guides through the treatment. Whoever's operating this is guided through the treatment of applying heat when it's max heat, being able to then apply the expression. And at the same time, Eric, you mentioned that you're actually able to see through the magnifying lens the exact glands you're targeting and whether or not that's successful. So as you're starting to get flow out of a meibomian gland, you can pulsate that with your thumb on the device and continue to get that response to the treatment you're looking for. So I really like the idea that you can personalize it and that you can see the results that you're getting. And again, in 8 to 12 minutes. And I think that, as people get faster and faster with it, that 8 minutes is a very reachable, certainly between 8 and 12.
Doug, do you have the same experience that I do when you do the iLux therapy? You watch the meibomian glands being expressed, and it's just exhilarating. I take a special pleasure in watching meibomian gland becoming unplugged, and watching these clogged oils turn to liquid in front of me and being expressed. Or am I just a little bit different about these things?
No, well, if you're different, Eric, we're both different, because I get a great thrill out of that. It's kind of like, throwing a pass and seeing that completed nicely. It just is one of those experiences where you're helping that patient. They're going to see a difference in that, and that it's going to improve their their quality of life. So no, I feel the same way. It's like touchdown.
All right, so there's at least there's one other person like me around.
There's one other.
So let's look at this video. Doug, please give us a blow-by-blow detail of what's happening here.
This is our friend Damon Durker. He's been in some of the other lectures in this whole symposium. And now this is when he's actually loading the activator onto the edge of the iLux. So you just unpeel it, and you're going to be doing both eyes with the same activator. And it's always helpful, and you'll see Damon do this, actually put the patient's head back against the rest. That just eliminates a little bit of movement. And then he's capturing the lid, and you can see on the actual display, it's walking him through what he's actually doing. Capture and then start the actual heat. And there's the light that he's starting the heat. And now it's going to monitor the temperature as that lid continues to get up to the ideal temperature, typically a warming of about 40 seconds. As this continues to go up, then the screen will actually tell him at this point, time to express. And this is the melt time right here. And then as we get up to that 40 seconds, then we'll switch over to the expression mode. Again, it's telling you just with a simple thumb switch here. And this is the view for the magnifying lens. And you can see that meibum coming out of the meibomian glands. Now, Eric, I really prefer the ones that are more volcanic in nature, where you really see them coming out and it's discolored. That's what I find. This is when Damon, now what he does at this point is he flips it upside down. The screen will reverse. You don't have to read it upside down. Everything that's being told reverse, and you do the upper lid. So simply doing 2 locations on the lower lid, 2 locations on the upper lid is going to cover the vast majority of those meibomian glands. And each time it's walking through, again, through the magnifying lens, you're seeing the meibum come out. So you know where you got the results. So if you've evaluated those meibomian glands, you're really going to have an idea, do you continue to press on something that's already atrophied? No. But if you're getting expression out, then you're going to go ahead and you're going to focus. And that really is the personalized care that I like so much about the iLux.
Couldn't agree with you more. Very fulfilling. I love it coming out. I like when the toothpaste comes out, but that was a nice example that Damon provided us right there.
I know.
So let's talk about a couple of studies now, because I think it's nice to talk together but I'm a big believer in peer review studies and science. And I think that science shows us that the iLux machine works extraordinarily effectively. And this is a study that was performed by a leading group out of San Diego, some good friends of mine there, actually. It's a very nice study. And what I like about it really is it shows the rapidity of onset of sign and symptom improvement in patients following the Systane iLux MGD thermal pulsation system. And this was an open label study. It was non-randomized. There were 30 patients. And we just wanted to look at meibomian gland function and evaporative dry eye symptoms after treatment with Systane iLux. And the primary endpoints were looking at meibomian gland scores and tear breakup time, which are two great score endpoints for patients with meibomian gland disease. We also looked at speed and OSDI symptom scores. So we looked at signs, we looked at symptoms, and we assessed the patient preoperatively at 1 week and at 1 month post-treatment.
I think it's important in looking at some of these measurements. This meibomian gland score, if you're not familiar with that, that's actually looking at 15 meibomian glands and scoring those meibomian glands from 0 to 5. So an optimal score, to bear in mind, would be 45. And when we take a look at these study patients, in some of these, we'll really see what the level was on these patients and then the improvement that we had.
Yeah, so it clearly did an amazing job. And here you see at 1 week following a treatment, following a single treatment, 1 week later, there was a 315% increase in meibomian gland score. Now that's a p-value, as seen here, of less than 0.0001. Those are numbers you never see in studies. That's an extraordinary p-value showing the clinical significance and the ability of the iLux MGD thermal pulsation system to open up the meibomian glands, and all regions were significantly improved. Now, tear breakup time is a direct correlation to the quality of the lipid in the tear film. It's very diminished in patients with meibomian gland disease, and here you're seeing a 71% improvement. To be quite honest with you, I don't think I've ever seen that in any other study before, to see tear breakup time so significant. And tear breakup time is really important because that's the thing that makes people's vision come and go. And I, for one, believe that visual fluctuation is my favorite symptom. And yes, Doug, I do have a favorite symptom. And that symptom is visual fluctuation. When patients' vision gets disrupted, when they say, I can see well between blinks, or I look at my computer, it gets blurry after a while, or I'm driving and I see clearly and then the vision changes, it's not that their cornea is changing or their IOL is changing, it's that the tear film is changing. And the tear breakup time is the best correlator to visual fluctuation. To see a 71% improvement is dramatic.
Well, Eric, I think we're brothers from another mother, because not only do I love to see that meibum and that thick meibum come out of the lids, I also feel that visual function is the most important symptom, and sometimes an overlooked symptom, because, you know, as you start to have neurodownregulation, a lot of these patients don't feel some of those typical symptoms, but they're going to see those symptoms. And after all, that's what they're coming to us for, is to see better. And yeah, I agree. It's the visual function.
So when you go back to your offices after this lecture, that's the one thing I want you to look for is listen to what patients have to say. They will guide you to the right diagnosis. You don't even have to look at the patients very commonly. You can actually just hear what they say to you. When they say that the vision fluctuates, and it can be any different aspect of visual fluctuation, as I mentioned before. It can be morning to night, it can be on the computer, it can be when driving, it can be any number. You're going to see that the patient has meibomian gland disease almost all the time. And symptomatically, these patients also showed significant improvement. And what I like here is the correlation between the speed score and the OSDI score. These are the two classic questionnaires that we use in clinical practice and in clinical trials to evaluate whether a dry eye product has improved the patient's quality of life. And a 53% improvement and a 58% improvement are marked improvements. Again, showing that not only was the patient's signs improved, but the symptoms were improved as well. And these improvements were maintained for a full month after the therapy. So they didn't last for just a day or two. They lasted a week. They occurred very early, and they lasted for a very, very long time.
And again, looking
Um,
at the p-values of all of those are
yeah,
extraordinary. Like, how many times in studies do you see those kind of p-values?
not often, especially in dry eye studies,
Yeah.
especially in dry eye studies. So the results of this study, basically the take-home message was no adverse events or serious adverse events reported. Pain scores increased post-treatment, but returned to treatment values at 1 day. 1 week post-treatment pain scores were significantly lower by enormous p-values. There was no clinical significant change in IOP as you would expect there would be, and there was no change in lid abnormalities associated with the treatments. So let's go on to the next study.
And I think this study is important because it answers the question that everybody's going to ask on this iLux device, and is how does it compare to other devices? And so this is a study that took 142 subjects. It was randomized, open label, and multi-site. And it compared against what has been the gold standard, which is the automated thermal pulsation or the LipiFlow. So taking a look at meibomian gland score, tear breakup time, secondary endpoints as OSDI scores, and again, assessing this at baseline, looking at 2 weeks and looking at 4 weeks post-treatment. And I think this is a very impactful study because we want to know, well, how does it compare to other devices that are out there? Because we're using something that is manual and we're really doing provider control versus being automated.
I also want to mention that the doctors who did this study, both optometrists and ophthalmologists, are among the best people I know. This was a real quality study, and a shout out to some people like Joe Tauber and Mark Blumenstein and John Hovannessian, among others. This was done by really the grade A clinicians that I really rely upon their data, and I just know they do great studies.
And what this really showed at 2 weeks and 4 weeks, average meibomian gland score going up 300%, like we saw in the last data, 317%. Average tear breakup time, again, consistent numbers. At baseline, it was somewhere around 4 seconds, and then 6 seconds at 2 weeks, and at 4 weeks, going up 74%. Again, very, very consistent. But I think what's really important when we look at these numbers is when we take a look at the OSDI scores, and when somebody is in the severe range and at 2 and 4 weeks they can move into the mild range, that's patient satisfaction. Those are patients that are going to notice the difference of the treatment that was applied to them.
Couldn't agree with you more. So we as clinicians like to look at signs. Patients don't really care about signs. They care about how they feel, their symptoms. And this was a dramatic improvement in symptoms here. Absolutely terrific.
What the study showed in the outcome is that there was non-inferiority. And as you, the graphs aren't in here, but as you look at those graphs for tear breakup time, as you look at for the OSDI scores, as you look at the meibomian gland scores, between the, looking at the iLux and looking at the LipiFlow, they were parallel. You can't see a separation in that. So it really showed non-inferiority. Now, when we look at safety, as goes with the thermal pulsation, with the iLux, there was 4 device procedure related adverse events. Now, all of those were in the iLux, but they were self-limited, transient, and they resolved without any further soliloquy. And they were things like PEK, they were like lid tennis, petechial hemorrhages in the lid. Again, everything resolved without any type of treatment necessary and resolved on their own. The pain scores really didn't differ significantly also between the 2 devices at day 1, week 2, and week 4. And in both devices, no clinically significant change in IOP, because we're always concerned about that in any type of procedure that's putting pressure. In the post-treatment improvements in the pain scores, didn't differ significantly at 2 weeks and at 4 weeks with the discomfort scores. Now, what is impressive is that the average best corrected visual acuity improved from 0.02 to 0.04 logmar in both of the devices. That is no significant difference between the group, and the p-value was slightly less than 0.05. But we were still seeing an improvement in that visual acuity and both of them very similar between the two groups. So when we're looking at non-inferiority, this proved and really substantiated that you get the same type of outcomes against something that was considered, has been considered the gold standard for a lot of years.
So iLux improved signs, symptoms, and visual acuity. I think that's a pretty good testimonial to how important it is to treat meibomian gland disease. So let's do a couple cases, Doug. Why don't you do the first one here? This is a nice case.
Okay. Okay, this is Jane, and she's a 46-year-old, and this would be somebody in the certainly within that that sweet spot that we'd see a lot of patients. But with that said, I think we kind of start looking maybe too late at some of these patients. I think that study that Priya Gupta did out of Duke University showing, that of 150 of her pediatric patients between age 4 and 17, that 42% had clinically significant dropout. I know when that data was presented, I was just stunned by that information. So, we don't necessarily correlate it with age. We need to look at a lot younger patients for this as well within those primary care practices. And we see in the meibography in this patient, in Jane, that she has significant dropout. You can see the atrophy, you can see the truncation, and that's looking at the structure of the glands. And then when we actually look at the meibum through expression, and we look at the tear breakup time, that's telling us what is that defect in structure, what is it doing for function, breaking up the tear. So as we look at Jill, she has a dry eye disease, blurry vision, which is again that key symptom, and a speed questionnaire of 19. Now in our clinic, a speed score of 6 or above is going to generate osmolarity, inflammation, and meibography that we're going to take a look. This patient has a speed score 3 times that generates tests. And she has just really palliative therapy up to this point. She's not adequately controlled on over-the-counter artificial tears, lid scrubs, and warm compresses that she's been using for the past 3 years. And in the past 6 months, another eye care provider jumped in with a therapeutic using an immunosuppressive of cyclosporin and administering that on a BID basis. She has lash debris, and as we see that truncation of the meibography, and dilation of those meibomian glands, and then atrophy in both eyes. So, we're diagnosing it with dry eye symptoms, with severe MGD, OU, and of course, blepharitis with lid debris movement. So this would be the ideal patient that would benefit because, and I'll tell the patient, I'll look at this meibography and I'll say, I'm looking at something that concerns me. I see that you're starting to atrophy, you're starting to drop out because of obstruction. But the good news is that you have enough structure that we can rehabilitate this through doing a procedure based, a mechanical procedure. So I'll tell them that, you do have, there's this problem that's leading to your symptoms, but we do have an answer, just like we talked about in the iLux. So let's take a look at the results with this patient.
Yeah, Doug, I just want to jump in and say that for me, I tell the patients exactly what you've just done. And I know you do this as well. I showed them a meibography and I showed them the dropout and I said, this is what a normal picture should look like. This is what yours is. And there's nothing more disruptive to a patient than showing them that they've actually lost anatomical structure due to their dry eye. And the prognosis is, if it's like this at 46, what's it going to be like when this patient's 70 years old? I mean, what's going to be left behind? So treating these patients, I think, is an imperative.
Yeah, absolutely. And then let's take a look at the results then after treatment. This is 6 weeks post iLux treatment. And the patient initially had a BluffX procedure done to remove debris. And, Eric, I don't know if you do this in your clinic, but what I do is I'll typically do a microblepharal exfoliation prior to the iLux just to try to free up the biofilm and free up the orifices as much as possible. You do that?
Yeah, I think BluffX is the perfect partner for iLux, and it really does a great job. And I think of BluffX as going to the dentist and having your teeth cleaned. It removes the biofilm. In the dentist office, we call it plaque. In the ophthalmic optometric networks, we call it biofilm. And it opens up and provides a clear pathway to open meibomian gland obstructions, which makes the iLux therapy that much better.
Yeah, and that I've always used that in combination with any thermal pulsation is do that first, try to give it, and that analogy, I use the dental analogy all the time, that before we started removing that biofilm and the plaque between the teeth and the gums, gum disease and gingivitis was just rampant. And since that point, with removing that with dental cleanings and with flossing, we've just that's been reduced tremendously. Now look at 6 weeks with this patient. Their speed score went from a 19 to 6. And what that tells me is that has been reduced tremendously. Now this patient still has that cured everything? No. This patient's going to need to be monitored. This patient's going to need treatment because they're still at that level that we use to initiate some of that testing. But that's a dramatic improvement going from 19 to 6. I would be very pleased with those type of results because that patient notices that improvement. And the patient also is using warm compresses and lid scrubs as well as cyclosporin. And I think that that's a good adjunctive therapy. I don't necessarily take patients off that because they've already proven themselves to be a dry eye patient. I go ahead and do something else that's going to help reduce that inflammation because we know their physiology wants to gravitate toward obstruction. So as we look at their lids, it's now 1+ MGD on both eyes. The conjunctiva is clear. The tear breakup time is now 6 and 8 seconds. The anterior chamber deep and quiet, the iris normal. As we look at the osmolarity, now the osmolarity is in a normal range. It's hovering right around 300. And the MMP9s, and this is really impressive, the inflammation is down because the MMP9s, or the inflammatory, is actually negative. And the meibomian gland scores are now 12 of 15 and 10 of 15. So we're really getting a significant improvement in those meibomian gland scores. So this ideal patient to approach, and the results show exactly what is very, very typical that we see when we're treating these patients, is that they have an improvement, and that's what the studies indicated.
Yeah, so the iLux was terrific here, but I want to just say again, I think that BluffX makes an enormous difference and really augments significantly your thermal pulsation that you're doing here. So a great combination therapy and a great case study. So let me show another case. Case 2, Paul. Is Paul Karpecki 78? No,
but he's aged very well if he is.
He's good. I think it might be all the wine he drinks that does it. But anyway,
wine's preserved him.
This is a hypothetical Paul we're talking about. He's a 78-year-old male. He's preparing the ocular surface for cataract surgery, and the patient comes in, doesn't really know that they have ocular surface disease. They're just coming in to see us for a cataract evaluation. They complain of blurry vision, light sensitivity, no significant history. But when we look at the cornea, the tear breakup time is markedly decreased. There are SPK, there's actually staining of the cornea. And to me, that's an absolute red light. When I see staining of the cornea, I don't do cataract surgery or LASIK for that matter until I resolve the ocular surface, because I'm just asking for trouble. Vision is 20/30 and 20/40. The patient's got some hyperopic astigmatism and presbyopia. And pre-Systane iLux keratometry, you can see here what the topography shows, what the total corneal astigmatism was, what the lens star showed, what the variant showed. And you see here that there's a good deal of astigmatism in that right eye. But look how the axis changes after treatment. It goes from 67 to 54 degrees. That's an enormous difference. In the left eye, the cylinder doubles and the axis changed on the topography. Lens star, which is kind of the gold standard for keratometry for me when I'm doing cataract surgery, is to do an optical biometer. It shows again a significant change in the magnitude and the axis of the cylinder. Post Systane iLux, there's just trace SPK inferiorly. It's not in the visual axis. You can see here on Cassini that there's just a marked change in right eye keratometry following the iLux. The cylinder has changed very dramatically. The axis has changed, the magnitude has changed, and that's going to dramatically change your IOL calculations. Here's a left eye showing very similar results. again showing a marked change in both magnitude and axis of cylinder following Systane iLux to allow the patient to get their true keratometry for IOL calculations.
So really what we've talked about today is we've talked about a prevalent problem and that affects a tremendous amount of the demographics of your practice. And one of the things I always encourage, if you haven't yet adopted treating meibomian gland disease, then do a little your own marketing study within your practice. Take a week, take a little score sheet, and have them do a survey, and then press on those meibomian glands. And even if you don't have anything else, even if you don't do anything with that, collate that data over 1 week and find out what portion of your patient demographics could possibly benefit and improve their lifestyle and improve their visual function by providing this service to it. Because this really is a provider-controlled and a personalized type of meibomian gland expression and thermal expression that can increase the revenue stream, but more importantly, provide that extra level of care. So do your own personal demographics and find out how many patients are you not treating that perhaps should be treated, because they will eventually find their way to another practice where if the symptoms get enough for those patients and it hasn't been addressed. So the iLux system uses the LED light-based thermal energy. The device can do both eyes in about 8 to 12 minutes. And in 1 week post-treatment, we saw increases in meibomian scores of 315% versus baseline. I really like the idea, Eric, that this is so portable and that you can take it from exam room to exam room to satellite clinics, and it works well. And don't think that once you actually start doing this therapy that you're just on your own. I think all of us have seen equipment that sits and gathers dust. I think Alcon does a tremendous job in helping the practice integration and working it into your workflow and working with your staff.
Meibomian gland disease is everywhere. I think it's directly correlated to age. I was involved with a study. Bill Troutler was the first author, called the FACO study. And we showed that people coming in for routine cataract surgery, 60% of them had abnormal tear breakup time, and 80% of them had corneal staining. So this is everywhere, and I think a vigilant evaluation of the patient, not only before surgery, but any patient comes to the office, start your examination by looking at the eyelids. If the eyelids are abnormal, I think devoting some time and effort to improving the meibomian glands is really important, and I think that the iLux, Systane iLux system is one of the benchmarks, one of the linchpins in making meibomian gland disease better managed and improving patients' dry eye signs and symptoms and quality of life.
There are questions that we can answer from the audience.
Thank you all for joining us. We'd be happy to take some questions.